Then Dr. Mohan Gowda, use of new alternative techniques in dealing with ptosis in special situations.
Good morning all. I'll be presenting on use of new alternative techniques in dealing with ptosis in special situations. So as we all know, correction of ptosis is essentially surgical. The most common techniques used in adults are tarsal transfer techniques, which can also be called as tarsal switch technique, Muller muscle conjunctival resection, and white line advancement techniques. In severe congenital ptosis, we prefer a frontalis flap technique. So this was the first case where the patient was presented with mild to moderate ptosis of the right eye, and he underwent Muller muscle conjunctival resection, posterior approach mainly, and similar case with bilateral mild to moderate ptosis, and the patient underwent Muller muscle conjunctival resection, where we approached through the conjunctiva and we resect a part of Muller's muscle along with a piece of conjunctiva. And then this was a 60-year-old female with severe myogenic ptosis, and here she underwent tarsal switch technique, where a piece of tarsus was removed from the upper eyelid, and we can observe she also had ectropy on both lower eyelids, and even ectropy was corrected post surgery. Similar patient, male, 80-year-old male, and he also presented with bilateral myogenic ptosis, and he underwent tarsal switch technique for that. And this was a 10-year-old male presented with congenital ptosis of right eye, which was here, and very poor levator palpebral function. So he underwent frontalis flap advancement technique, where frontalis muscle was attached to the upper eyelid along with levator and orbital fat. This was again a case, a female child with left eye, severe congenital ptosis, and she underwent frontalis flap advancement. So this was a 30-year-old female with mild to moderate ptosis. We went ahead with white line advancement, where the levator palpebral superficial aponeursis was advanced to correct the ptosis of the left eye. So basically all techniques gave satisfactory results. A few techniques required revision surgery. None of the patient developed any complications like exposure keratopathy, suture granuloma, or congenital prolapse. So the possible complications we expected were like undercorrection, overcorrection, lag of thalmus, or exposure keratopathy, eyelid contour defects, conjunctival prolapse or eyelash prolapse, or in a kind of suture granuloma. We couldn't find any of those in our cases. So concluding, the ptosis correction helps restore visual field. Multiple techniques depending on each case should be used. So selecting the right technique based on the type of ptosis is quintessential for optimal results. Thank you.
Okay, one of your patient had markers and jaw winking phenomenon. So could you address his problem, that jaw winking phenomenon, along with the frontalis muscle advancement surgery?
Yes, excitation of the nerve will solve this jaw winking. Excitation of the nerve.
What do you mean by a tarsal switch technique? Is it? What was that? Tarsal
Tarsal transfer technique.
Tarsal transfer technique. What is that tarsal transfer technique?
A piece of tarsus from the upper eyelid is
Please use microphone.
a piece of tarsal from the upper eyelid is taken and put at the lower.
A piece of tarsus from the upper eyelid is taken and placed in the lower lid. Is that what you're saying? How is going to correct the ptosis if you take tarsus from the upper lid and put it in the lower lid?
It was a full thickness or partial thickness?
Sir?
Full thickness tarsal plate, piece of what, tarsal plate or partial thickness?
I'm not aware of the technique.
Raghu can actually.
Have you done it?
Raghuraj, maybe you want to answer that for the audience, because all of us are a little curious about this.
Yeah, please.
The mic is right behind you.
So we don't use it for the regular situations. It's not for a regular ptosis. So we use this in cases where there is, in cases of CPEO, where the closure as well as the opening, levator function is poor. So what we do is basically the whole concept is basically you shift the palpebral fissure from below to above. So you shift the part of the tarsus while maintaining 4 millimeter margin, and shift the upper side of the, upper part of the tarsus to the lower lid. So the lower lid comes up, the upper lid also comes up, and then you suture it from inside.
No, but you have the upper lid, lower lid, which is independent. It's separated.
Correct.
how can you switch the tarsus from the upper lid into the, you mean to say you'll excise the tarsus from the
Excise
upper lid
tarsus completely
and then
yeah,
place it in the lower lid transconjunctivally, is it?
transconjunctival. And
Below
shift
the
the,
lower,
below the existing
So
tarsus.
basically you're trying to decrease the interpapillary,
No, we are
trying
shifting,
to-
we're shifting it superiorly.
okay, but why do you want to place the tarsal plate in the lower lid? You might as well leave it, no? The upper lid will go up.
But it will go up.
Yeah, that's what you want, no?
Yeah, we want the lower lid also to go up. We want the upper
Why do you want the lower lid to go up?
Because the closure is the problem. So
The
it-
closure is the
Closure
problem.
is a problem in CPO patients, and previously we couldn't offer them much help with we would have to give a
Why can't you
crutch
just put
class.
a silastic sling as what we normally
No,
do,
but, then
which
you
is
have to
adjustable?
undercorrect it, and sometimes that it comes down, so you have a recurrence after.
That's the whole idea is it's adjustable. So the patient has got exposure in future. You can always adjust it, and if you want, you can take it off also.
This gives more predictable results, and I've been doing it for some time, so I feel it's a superior method to a sling because you are just helping him get the visual field in. It will clear the visual field. Basically, it will help him in ambulatory vision, and many of
Okay.
these patients are quite old, so it helps in independence. And crutch classes, many patients don't appreciate it. Even I have had cases where after sling also we've had to give crutch classes because it recurs eventually. So,
Okay.
so that's.
Thank you. Thank you.
Just a suggestion is that the presentation with the photos were very impactful, but if there's a little more, say maybe like a compilation in terms of what was your methods, what is the etiology in which cases, and what was the procedure done and the results, that adds a little more method
I
to
think
the entire process.
it should be more
Structure.
structure, especially on technique and indications.
I have done so. Your question is, can we, for CPO, whether to do a frontalis, just like a tarsal switch, do a frontalis flap and add a spacer graph. I think in concept it sounds the same, but yeah. You will have the upper tarsal intact and the frontalis, but I think lag of thalamus is a very, very serious problem with frontalis flap. Although long-term results from what papers we've read, lag of thalamus after frontalis flap is lesser than that of a sling. Duration for recovery of lag of thalamus post frontalis flap is far more than that of a sling. I'm able to comfortably remove a frost suture after a week after a sling, but sometimes I have to keep it on for 3 weeks after frontalis flap. And those 3 weeks may be very worrisome for the surgeon, if not for the patient after that surgery.